Good afternoon. Welcome everyone to our Hospital Management Asia webinar on tackling APEX doctor shortage and burnout with innovation and technology. I'm Cindy, Content Manager at HMA, and I'll be your MC this afternoon. So today we have invited a panel of healthcare leaders from across Asia to discuss the growing crisis of doctor shortage and burnout in our region. So you might already know that most, if not all, Asian countries fall below the OECD average of 3.8 doctors per 1,000 people. Many countries here also face an imbalance in distribution of doctors between urban and rural areas, which lead to long working hours and burnout. So how can healthcare providers like yourselves tackle this issue? Is having more doctors the best solution? Or can we leverage technology to help support our doctors to do their best work? So over the next 1.5 hours, our four speakers will share their thoughts on this critical topic. So we will have a 10-minute Q&A session at the end. So feel free to share your questions in the Q&A box located at the bottom of your screen. Right, so before we jump straight into our session, we have a short poll question just to understand how many of you in our audience face a shortage of doctors in your facility. Right, so there are four options. You should see a pop-up with four options. You do not face a shortage of doctors. You face a shortage, but it's not very severe. You face a significant shortage of doctors, or you face a very severe shortage of doctors. Right, so we'll just give everyone, say, about 10-20 more seconds to put in your answers. This is just so we get a sense of how our audience members today um, are addressing or facing this issue at your own facility. Right, so, yep, so say about 5 more seconds here. Okay, and I think we have seen some responses come in. We see that most of you do face a shortage, whether it's significant. So 34% of you said that it's a significant shortage, and almost above half of you actually said that you face a shortage, but it's not very severe yet. So thank you all for sharing your responses to this question. And we will, I think today's topic is just very timely for all of us to look into this growing crisis across our region, right? So thanks once again for everyone's responses. I'm now pleased to invite our first speaker, um, Dr. Eddie Gunawan, CEO of MRCCC Siloam Hospital Semanggi, to present his thoughts on Indonesia's shortage of doctors. Dr. Eddie, please.
Hi, thank you, Cindy. Please give me a moment to take my presentation and share it. Can everyone see my screen now?
Yes, I can.
Oh, yeah. Okay. Thank you, Cindy. Well, good afternoon, everyone. Thank you for the opportunity to be part of this webinar. Apologies, my voice is a bit hoarse as I'm feeling a bit under the weather today. Thank you for joining today's session on addressing the doctor shortage in Asia with a specific focus on Indonesia. I'll be sharing insights on the current healthcare challenges and Siloam's integrated approach to tackle these issues. Now, the shortage of healthcare professionals in Indonesia is a significant issue. Indonesia's ratio of doctors per 1,000 population is 0.6, significantly lower than other countries in Southeast Asia, and making it one of the lowest doctor-to-population ratios in the region. As of 2023, the country is facing a shortage of both general practitioners and specialists, with a gap of over 101,000 doctors. The ideal number of doctors needed is actually 277,000, while only 175,000 are available and just 144,000 are actively practicing. The specialist shortage is even more concerning. With a target of 0.28 specialists per 1,000 population, which is not a very high target, Indonesia still has a gap of over 25,000 specialists. And for many specialist craft groups, at the current rate of specialist production per year, this gap may only be closed in more than 5 to 10 years. Well, on the table on the right side, take anesthesiology, for example. With a number of 3,300 existing anesthesiologists, there's a gap of 5,000 anesthesiologists for Indonesia, while the current rate of anesthesiology graduation per year is only 200. So that will take us even more than 35 years to fulfill the gap. The doctor shortage issue is not only about numbers. If we look at the geographic distribution, over 60% of specialists are concentrated in Java Island, leaving 30 out of 38 provinces in Indonesia with inadequate access to healthcare. Especially in the eastern part of Indonesia, 38% of the district general hospitals lack the 7 basic specialties. While in Indonesia, we take internal medicine, pediatrics, OBGYN, surgery, anesthesiology, radiology, and clinical pathology as the 7 basic specialties that every hospital should have. In the remote regions, take Papua, for example, the situation is even extremely critical, where in the primary clinics, 41% of the primary clinics have no doctors at all, not even a general practitioner, let alone specialists. Becoming a specialist in Indonesia is a long and challenging journey. Approximately 12,000 new general practitioners graduate each year, but only 2,700 become specialists. This is largely due to the limited number of specialist training centers. Indonesia still uses a university-based training model, and out of 92 medical schools, only 21, most of them are public universities, are licensed to train specialists. And compounding the issue are high tuition fees and the fact that the specialist trainees earn little or no income during the typically 4 to 6 year program. These factors create significant barriers, especially for candidates from lower income backgrounds. If we look at the subspecialist training, it's even more limited, with only 17 licensed universities and an annual intake of just 400 applicants across diverse subspecialty fields. Indonesia's government has been working on several national strategies to address the doctor shortage. I'm not going to take much time explaining this, but principally the government has been working on expanding training capacity and increasing the intake of medical students, offering scholarships for medical education with a significant focus on specialists and subspecialists, engaging the Indonesian medical diaspora to bring talent back to the country, and strengthening the health system through modernization projects and infrastructure upgrades. And recently, the government is also considering implementing a hospital-based specialist training program. Now, this situation places a burden on hospitals, especially private hospitals like us, especially the ones that are outside of Java Island. Now, to put our perspective into context, MRCCC is actually a part of the larger Siloam Hospitals Group, which is committed to providing quality healthcare to all Indonesians. Siloam Hospitals Group operates 41 hospitals across the country, and not only in major cities, but also in smaller second and third tier cities. In addition to hospitals, Siloam also runs multiple clinics at various locations, including in Papua, where access to healthcare is most limited. As of 2024, Siloam Hospitals Group operates over 4,100 beds, admits over 325,000 inpatients, sees over 4.1 million outpatient visits, and performs over 115,000 surgeries annually. To address the doctor shortage, Siloam focuses on building the next generation of healthcare professionals while enhancing the efficiency of the existing workforce. In building our next generation, we offer full scholarships at all levels, from GP to specialist, from specialist to subspecialist, and even for master's and PhD programs. Aside from that, Siloam is also affiliated with University of Pelita Harapan, a private medical faculty ranked first in Indonesia by EduRank. University of Pelita Harapan is also the first private university in Indonesia licensed to train specialists. And the current specialist training programs include radiology, family medicine, and anesthesiology, with more programs under review. Aside from university, Siloam also runs its own Siloam Training Center, which offers tailored training in specific areas like hemodialysis, chemotherapy, emergency care, and both for doctors and other healthcare professionals. To improve efficiency, we also leverage on technology such as teleradiology, and also we implement the hub and spoke model. And of course, we continue our outreach mission through the Papua Clinic. In Indonesia, radiology is one of the rarest specialties. This map shows the radiologist availability in the provinces where Siloam is present. In many of these areas, the radiologist to population ratio is extremely low, sometimes even less than 0.005 per 1,000 population. And in our experience, in some of our hospitals, the only radiologist serves an entire city, or sometimes in some places, even the entire province, and is only available at one hospital for only a few hours once a week, since he needs to attend multiple hospitals within that city or even within that province. This situation, of course, leads to prolonged turnaround time and reduced diagnostic accuracy. So teleradiology really allows remote health centers to access expert readings from centralized radiologists, and at the end of the day, improving the care quality in underserved regions as well. We have established a strong radiology network, Siloam Radiology Indonesia, with over 60 radiologists, including 24 subspecialties within radiology itself. Using a centralized PACS, radiologists can read images from any hospital within our network. We implement a double reading for education and quality assurance, in which we arrange a team of general radiologists to be paired with a subspecialist for training and review. These general radiologists are then assigned to a specific field of radiology, such as cardiothoracic imaging, take for example. And then their interpretations are reviewed and revised by a cardiothoracic radiologist consultant. This approach enhances the competency of our general radiologists over time and has enabled us to achieve a 95% diagnostic accuracy. Since this model also ensures timely radiology reporting, it is especially valuable in supporting rapid stroke, CT scan, and or MRI interpretation. It allows us to deliver timely thrombolytic therapy to patients with newly onset non-hemorrhagic stroke, ensuring that all our hospitals remain stroke ready across our network. Then another initiative we run is the hub and spoke model in oncology. Well, as we know that MRCCC is the only private cancer hospital in Indonesia, aside from the government-owned Darmais Cancer Center. Given this situation, two main problems arise. One, capacity is never sufficient at a national level because these two hospitals will never be enough to serve the whole country. Two, building oncology capability outside Jakarta is very challenging due to the limited number of oncologists. Despite these constraints, MRCCC has successfully implemented a multidisciplinary approach for the most common cancers, where patients are treated by teams rather than individual oncologists. However, this is not feasible in remote areas. So we leverage the advantage of being part of the larger Siloam Hospitals group. MRCCC implements a hub and spoke model where MRCCC acts as a hub and is supported by its spoke hospitals. MRCCC oversees the spoke hospitals, ensuring that services are delivered in accordance with established standards. Spoke Hospital B is expected to be able to deliver chemotherapy, surgery, and radiation therapy to some extent, while Spoke Hospital C is expected to deliver basic diagnostics. We also conduct internal group consultations where patients treated at Spoke Hospital B and C can be discussed with the MRCCC team and only need to be physically referred to MRCCC for advanced treatments like bone marrow transplants or nuclear ablation. Furthermore, Spoke Hospital C with very limited oncology capabilities are expected to focus on diagnosing cancer and systematically referring their patients through an established referral pathway. In some cases, MRCCC doctors may also travel and fly to spoke hospitals to perform procedures on site. Now, I want to take a moment to reflect on Papua, where access to healthcare remains extremely challenging. As I've mentioned earlier, the interior of Papua is among the most isolated regions in Indonesia. And when I say the interior of Papua, I truly mean the deep interior. While major cities in Papua may have hospitals and basic infrastructure, there are still countless villages in the inland regions that remain completely isolated, untouched, and disconnected from the outside world. In these remote highlands, even general practitioners are extremely rare. Specialists are practically non-existent. I myself served some time in Papua, and when I was there, I was the only doctor covering the entire mountainous region of Mamit village in Papua. And patients often had to walk 1 or 2 days on foot just to reach the clinic. Many areas are so inaccessible that advanced technologies or complex referral systems simply cannot be applied. Take for this example, in this picture, the only means of transportation to this place is this small propeller plane. And the quote-unquote airport is just a little more than just a dirt strip carved into the mountainside. No terminal building, no control tower, and the pilots must navigate dense fog and rugged terrain, fully relying on their experience rather than instruments to land and take off safely. The local population lives in extreme conditions. There are no paved roads, no access to clean water, no electricity, and even their homes are still makeshift huts, as you can see in the image. So basically, infrastructure is nearly non-existent. And in response to these conditions, we operate 7 clinics across 7 different remote locations in Papua, delivering free essential care when no one else can. In this part of Indonesia, the health system is still struggling with the most basic challenges. Early marriage is common, and as we know, pregnancy in young women often carries higher risks and complications. Yet there is no one trained to do antenatal care or assist with childbirth. When labor begins, pregnant women typically go into the forest, accompanied by only an elder woman from the village, and the delivery takes place without any professional medical support. This leads to extremely high rates of maternal and infant mortality. Even when the baby survives, the families often lack the knowledge or resources to raise their children in a healthy way, resulting as you can see in the pictures in widespread malnutrition. Poor hygiene and sanitation only make things worse. Many children play with sharp tools like cleavers, knives, and they suffer cuts all the time, and they receive no proper wound care. Combined with their poor nutritional status, even these minor injuries can become dangerous. And on the right side of the page, this is a picture of the inside of a honai, their traditional hut. As you can see, it's just a single cramped space where people cook, people eat, sleep. Basically, they live together with no separation or ventilation. And in environments like this, basic services such as just childbirth assistance, stunting preventions are not just important, but they are just life-saving for the people in Papua. I'd like to share that at our clinics, we provide basic health services such as outpatient consultations. But in a vast and mountainous region like this, where reaching the clinic often requires walking for 1 or 2 days, these basic services become vital. To reach those who cannot come to us, we regularly carry out home visits to remote villages. And during these visits, we educate local communities, especially about nutrition, hygiene. We also treat patients who are too sick to leave their honai and evacuate critical cases to larger hospitals when needed. Take this photo, for example, the one in the middle. It shows a 10-month-old boy who had repeated seizures that did not respond to diazepam. In any standard setting, he would need an urgent blood tests and brain imaging to rule out central nervous system or metabolic causes, none of which are available in our clinic. So with limited resources and only one nurse on duty, the team made the critical decision to evacuate him to the nearest hospital, which is located hours from our clinic. And the journey made by this fiber boat with only basic evacuation equipment took hours. The seizures continued throughout. All our nurse could do was just to stabilize his general condition as best as possible. But at the end of the day, thankfully, after receiving intensive care at the referral system, this boy survived. But of course, sadly, there are many more children like him, children we can only hope will get the help they need in time. On the right side of the page, as you can see that we also partner with Sekolah Lentera Harapan, or School of Lantern of Hope, a school run by our sister organization, Yayasan Pelita Harapan, Foundation of the Light of Hope, to serve this region. So the school provides free education and clinic provides a free medical service. So we work together and we provide free vaccinations for these students who are also receiving free education at the school. Now, as I've shared earlier, childbirth in this region has traditionally taken place without any medical assistance. So we still honor this deeply rooted custom. So we began by training pregnant mothers and respected elder women in the community to assist during labor safely. In this photo, the mother gave birth at home. Outside, our health workers waited patiently because their traditional custom does not allow us to help the childbirth. Even a male doctor is not allowed to be in the same room with a female patient in this area. So typically our health workers wait outside, and when the baby was born, then he was gently wrapped in a noken, a hand-woven traditional bag, and warmed with leaves in his mother's arms. And soon after, our team will arrive, bring proper clothes, supplies, and then cared for the newborn with tenderness and respect. On the right side of the page, as you can see that we also run a stunting prevention program where we provide food and community kitchen for pregnant women and young children. Local women help prepare and distribute nutritional meals, typically just staples like cassava or rice, porridge, chicken or fish soup, as well as milk, fruit, and vegetables. Okay, I see that the committee has reminded me about the time. I could easily spend hours talking about Papua, but yeah, okay. So I'd like to close by saying that at Siloam, we firmly believe that access to healthcare should not depend on where you live or how much you earn. Healthcare is a human right, and it's our mission to uphold that right for everyone in Indonesia, no matter how remote their location. So in conclusion, while the shortage of doctors remain a serious challenge in Indonesia and probably across Asia Pacific, we believe it's a challenge we can overcome through creative solutions, smart use of technology, and strong collaboration. But above all, in the end, it is really our heart to serve that truly makes the difference. And it's this spirit that will carry us forward in addressing the doctor shortage. Thank you, and let me hand it back to Cindy.
Right. Thank you very much, Dr. Eddie, for sharing your insights into Indonesia's doctor shortage issue and how MRCCC and Siloam hospitals are doing so much to try and tackle this issue moving forward. So thanks very much for sharing your insights on this topic. I would now like to introduce our second speaker, Mr. Brian Lin, Regional Chief Executive Officer, Asia One Healthcare, and CEO of Subang Jaya Medical Centre in Malaysia. Welcome.
Thank you, Cindy. Good afternoon, everyone. I want to thank HMA for giving me this opportunity to share my perspective on the topic, as well as share with you some of the strategies that we have used to address these burning issues. So I'm going to share with you my deck about how we have addressed the doctors' burnout and the use of technology in our hospital. Okay, I think as we understand, right, globally, the healthcare system is under a tremendous pressure. We are facing a rising demand of patient healthcare needs and equally a growing shortage of doctors, and also an alarming burnout rate among the medical professionals. I think the purpose of my presentation is to share with you how we use innovation, technology to address some of these burning issues. I think globally, WHO have estimated that there's a shortfall of about 100 million healthcare workers by 2030. And the burnout rate is really high. 60% of doctors have reported symptoms of burnout, which include emotional exhaustions, depression, and reduced job satisfaction. So I'm going to share with you from a Malaysian perspective. If you look at this graph, it appears that the numbers are improving. And I think indeed, from Malaysian perspective, before COVID and after COVID in 2023, there is an improvement of a doctor to population ratio. As of 2023, we have 1 to 406 compared to before COVID, we have 1 to 482. Now, what is also equally alarming is that if you look at this chart below here, is housemen, house officers. These are people who have just finished their medical degree, and then they are going into the job in the workforce in the public sector, where they will undergo years of doctors' practical training. These are house officers who are in the public system. Now, if you look at this, there is a big decline if you compare those days, those years. For example, in 2019, we have about almost 12,000 house officers in our Ministry of Health system. And then if you look at 23, there's a big drop, almost more than 50% reduction in numbers of house officers in our public system right now. Now, this picture here actually speaks 1,000 words. And these are a recent picture that was taken and reported May of this month, 6th of May to be exact. Now, these are general practitioners who went down on a march to the capital city, Putrajaya, because they felt they were unfairly treated, because the government warned that all general practitioners display their medication prices. But however, they felt there was unfairness because their general practitioner consultation fee has not been increased for the past 30 years. And the picture over here on your right of the screen is that this just happened during COVID 2023, where the medical officers in the public system went on a boycott because they felt they were not appreciated. They were made contract medical officers, but they were not given a permanent job. So they went on a boycott in 2021. Now, the next few slides I'm going to share is those are statistics. Now, I'll just share with you first of all about local graduates. There is a severe decline in people entering medical school. So, for example, the number of medical graduates from local university has dropped by 32%. And the provisional registration, that means a decline in medical graduates, provisional registration by our Malaysian Medical Council has also dropped by 49% in compared to from 2017. Now, we talked about houseman earlier. There's also a big decline in houseman appointment in our Ministry of Health from 2006 to 2023. The number of house officers fell by 47% from 6,134 in 2019 to 3,271 in 2023. And what's more alarming is this. The housemen who graduate from overseas have plunged by 80% from 2019 to 2022. And this chart here this table here shows that the number of new registered doctors, those who are qualified doctors after they've gone through the training, has also dropped by 9% in 2023 compared to 2022. Now, that was in the public sector. Now, I'll just zoom in a bit about the private hospital workforce. In the private hospital industry in Malaysia, we employ about 19% of our 19% of our workforce consists of doctors. Compared to 2019, it's about 17%. Now, this percentage excludes consultant or specialists. In Malaysia, in the private hospital environment, majority of the specialists, they are what we call independent contractors, which means they are not employed by the hospital, but they are contracted for their services. Now, important thing to note is that from a private hospital perspective, when we look at the disease burden, it is an indicator of what the hospital need to focus on to get the right type of doctors in the private hospital industry. As you can see from the chart here, majority of the disease burden in the private sector actually is in cardiology as well as blood-borne diseases, followed by respiratory and cancer. And then the remainder, I wouldn't say they are no importance, but those are areas whereby there is a lesser demand. Okay, such as diabetes, neonatology care, nephrology, and back pain. Now, just to share with you now a bit perspective of who we are part of the Asia One Healthcare Hospital Network Group. We have about 32 hospitals in the region, in Malaysia, Vietnam, as well as Indonesia. And then we have about close to 3,000 consultants who are contracted with us to use our services. Now, if I were to just zoom in further, just on Subang Jaya Medical Center alone, we have about 260 specialists who are working in our hospital. And we see about more than 500,000 annual outpatient visits, and we admit close to 50,000 admissions a year. And in terms of the core discipline that we are focusing upon to grow our services includes cardiology, oncology, neurology, gastroenterology, orthopedic, women's health, as well as children's health. So these are the areas that we are focusing upon to recruit our doctors. And as a hospital, we've been recognized by the Newsweek, as well as JCI and ACHS Australia. Now, I'm going to share some of the strategies that we have used to address the burnout ratio of doctors. Basically, what we have done is that when we look at our need for a specialty, we look for the right kind of doctors to meet the disease burden that's required in hospital. So we are very focused in the type of specialty that we are recruiting. In terms of their medical training, the skill and expertise, but we look for those with high emotional profile. So having a high EQ is very important because we believe that doctors who are able to address patient needs are doctors who are good listeners and good communicators. Now, once we have identified the doctors, we actually give them a guaranteed income so that when they move from a public setting into a private setting, they do not have to worry about where the next meal will come from. So we actually give them a comfortable guaranteed income so they can focus on their private practice. And also an important strategy that we use is that before we recruit a doctor or when we have identified a doctor, we actually have a peer review. Every existing doctor in our facility would have an opportunity to review the incoming doctors, whether one, they're clinically qualified and competent, and more importantly, are they really a team player? Because we believe that in order to sustain a doctor practice in our environment, they have to be able to get along with their peers. Therefore, having a rigorous peer review is very important. And the other important thing that we take on is that we have a very multidisciplinary approach in addressing a disease. There are sometimes more than 3 or 4 various disciplines that actually look into a patient's disease. So we take a very multidisciplinary approach in addressing these issues. We provide opportunity for training and upskilling of our doctors. Okay, for example, we would actually sponsor our doctors and send our doctors abroad to be trained. Or when we embark on a new technology, we send them for training. We invest time and money to make sure the doctors has opportunity to upskill themselves. And equally important to retain specialists in our organization is we have inpatient medical officers to support them. Now, having medical officers in the hospital and in the ward doesn't mean that the specialist doesn't require to come see the patient. On the contrary, every specialist is required to see and attend to the patient on a daily basis. Now, these medical officers are assistants to them, so that in situation whereby the specialists are caught in a traffic jam or being held up in operating theater, they can actually call these medical officers to attend to the patient or attend to the relatives in case of an emergency or in case the patient or the relatives or family members have questions. So these medical officers are an assistance to the specialists. Now, the other strategy that actually we use hold on for a while, it seems to be having some problem with my PowerPoint slide. I'm going to stop sharing for a while. I'm going to try and reshare again because I think my slide doesn't move. Excuse me for a while. Okay. Second strategy that we actually have employed in our hospital is creating a digital ecosystem. Now, I mean, when we decided to do this in year 2016, we were probably one of the first few hospitals in Malaysia to actually embark on an end-to-end electronic medical records. Historically, we've been using a hospital information system, which is very paper-based. Every records or every medical folder got to be physically handed over after being retrieved from a medical record department to the clinic or to the emergency department. Now, in 2016, we have decided that the way forward is to use electronic medical record. So, and then since then, we have not turned back on that. And in fact, if today the system, the EMR system is slow, my doctors will be calling me so frequently about why the system is slow or why it's not working. So we do have challenges when we actually embark on this. There were a lot of pushback from the specialists, but today there's a lot of pushback for me if our electronic medical record is taken off the rack. So having an important system that works and robust is really important. Because with this medical record system that is shared across all 4 hospitals, it allows flexibility, it allows continuity of care, it allows a seamless experience to be able to provide. Now, continuing on our digital roadmap, the third strategy that we use is that we started to use innovation and artificial intelligence. On 2023, we embarked on. Now, before I continue, artificial intelligence is not a replacement of the doctor. It is only an assistance. Now, the connected care ecosystem was done to address the need, whereby we have a vision that hospital should be where patient is seen as not a patient, but patient should be treated as hospital. And healthcare is not about hospital. Healthcare is about providing good health to the patient. So with these 3 visions that we have, we started to build an ecosystem whereby we feel that patients need to be connected to a medical concierge, thereby we provide that medical concierge 24 hours free to the public. Explain to the medical professional what the simple concierge care can provide. We can be specifically our chest x-rays are AI driven. Again, this AI driven chest x-ray is not to replace the radiologist, but to enable the radiologists to pick up areas, have to go to that area and to accept or not to accept the particular area. So the other thing that actually we have done and the machine are calculating the movement, and then they're just able to radiate the targeted tumor. And the other thing that we have done also is to invest in precision and personalized medicine. We actually invested in next generation sequencing because this actually helped to make the oncologist and the doctor to have a better knowledge of what type of tumor or cancer they're dealing with. Now with NGS capabilities, they're able to say that no two tumors in the lung are the same. One can be treated with certain chemotherapy, and another one could be treated with a different regime of a chemotherapy or immunotherapy or targeted therapy. So with this next generation sequencing machine, our doctors feel more comfortable in the treatment of cancer. And we have also invested in robotic surgery. We have invested in the Da Vinci robotic surgery for our urologists, for our gynecologists, and also our general surgeon. And for orthopedic, we also invested in robotic orthopedic using the Mako robotic. And this has been used by our orthopedic surgeon to get very good results, especially when they do knee replacement surgery. And some of the examples of the technology we have invested in is that we have invested in a digital PET-CT, TrueBeam system, IORT, a full range of brain lab suite with navigation system, and also CartoPrime for our electrophysiologists, cardiologists, in order for them to do better interventional work in their in the treatment for cardiac patients. So these are some of the examples that we have used and investment that we actually embarked upon in order to take our treatment to the next level and also to help to retain our doctors. So just sharing with you some of the news coverage about our investment. For example, on the NGS machine, we were the first in Southeast Asia to provide an express turnaround time. So patients do not have to wait for the specimen to send overseas to another Western country and wait for 1 month or 2 in order to get the results back. But with this, we can get result within days and weeks. And it actually give very precise and personalized treatment to our patients. And with that kind of NGS investment, we are able to improve our survival outcome rates. For example, for breast cancer, our 5-year survival rate is 85% compared to other survival rate in US or Japan. Our NPC survival rate is about 73% compared to other countries of 65%. And colorectal, our 5-year survival rate is about close to 70% and compared to other countries' survival rate. And, you know, these are just some examples of how the investments are paying dividend for us, not only from a financial ROI, but also from this clinical ROI. Another example, and the last slide we share with you, is our investment in robotic surgery and our upskilling our doctors of how they can improve their surgical skill by doing TKR, but doesn't warrant patient to stay 3 days or 4 nights in the hospital. They can be done in the day, in the morning, and they can be charged the same day. And then our remote patient monitoring team will take over and nurse the patient at the comfort at their home. So we did the first total knee replacement surgery as a daycare center and in Malaysia, I think as well as in ASEAN region. So that's all for my sharing today. I'm going to hand back my time to Cindy. Back to you, Cindy. Thank you.
Yes, thank you very much, Brian, for your presentation and for sharing with us Malaysia's doctor shortage issue and how your hospital is trying to tackle it and all the strategies around recruitment and technology. So thank you very much. I'll now like to introduce our third speaker, Dr. Yasuharu Tokuda, Director of the Muribushi Project for Okinawa Residency Programs from Japan. Welcome, Dr. Yasu.
Thank you for inviting me for this important webinar conference. I will talk about the physician shortage, burnout, and CDSS in Japan with a case in Okinawa. I'd like to have an actual case conference later in this my session. My name is Dr. Tokuda. I'm a director Muribushi Okinawa Center for Teaching Hospital, Okinawa, Japan. I practice general internal medicine and I teach junior residents and I do clinical research. Let's look at the map. My colleague, Dr. Kaneko, developed Rurality Index of Japan, RIJ. This is based on the following 4 factors: population density, distance to secondary or tertiary care hospitals, remote islands, and weather influence on access to hospital, such as typhoon or heavy snowing. The map shows Japan faces significant geographic disparities in healthcare. Rural areas, especially remote islands, often struggle with limited access to hospitals, influenced by factors like population density and weather conditions. Okinawa is considered to have a relatively large number of doctors according to the Physician Maldistribution Index by government, but it is a highly remote area for medical care. As you can see in x-axis, the Physician's Maldistribution Index is a government-created metric, but it doesn't take into account factors like poor medical access in remote islands, which is why it doesn't correlate with the Rurality Index of Japan, RIJ. The problem is that the government metric still labels it as a prefecture with plenty of doctors. So let's look at the resident doctors, who are hardest working people in hospitals. We conducted the resident survey with sample size approximately 9,000. In residents with the 90 hours greater per week working hours, risk for burnout is greater. And next survey, in residents with the 90 hours or greater per week working hours, shorter sleep hours and poorer sleep is prevalent, much prevalent. So we also conducted the survey, the 6,063 residents nationwide, and residents reported 12% of them were actually involved with harmful patient adverse events. in patients over the past year. So 1 year range, about 10% of them had serious harmful adverse events in their patients. So we analyzed that. We identified factors significantly associated with harmful adverse events. These are the significant factors: emergency duty 6 or more times per month, greater than 15 inpatients in charge on average, greater than 80 hours of work per week, working at bedside average greater than 1 hour per day, and burnout, psychological stress from senior doctors, including bullying and harassment, psychological stress from nurses, and male residents. The female residents showed there was a reduced odds ratio for adverse events. So overworking among residents can lead to burnout and also increase the risk of harmful adverse events for patients. So let's look at the government response. We have work hour reform law in Japanese doctors started last year, April. The cap on overtime work for doctors based on the work hour reform law began last year. However, a cap of 960 hours per year, equivalent to 80 hours per month, which is considered the baseline from overwork. This is a well-known term, karoshi line in Japanese language, exceeding max of 720 hours per year in general industry. A special exception was also made for doctors in charge of emergency and remote or rural medical care who are allowed to work up to 1,860 hours per year. This exception is scheduled to expire in year 2035. So this is my solution for this shortage, overtime work, and serious harmful events prevalent. We call it e-diagnosis based on the CDSS, Critical Decision Support System, including UpToDate, PubMed, and Google Scholar, which is useful as a diagnostic aid in difficult cases. By appropriately utilizing this system for difficult cases, it may be possible to maintain patient safety and doctors' well-being, even in the face of a shortage of physicians, addressing some of the critical challenges in healthcare delivery across rural and remote regions of Japan. So in search engines or AI, if you try and enter key symptoms, physical signs, and testing finds of your patients, relevant information from extensive medical literature will be found. So this is an actual case from my experience. 70-year-old woman with a 3-month history of edema, abnormal hair growth, and numbness in the legs. The edema was present bilaterally in the legs. Also, abnormal hair growth, increased hair growth was found both legs and also numbness in the legs. The numbness, the location is the stocking type location. Now, let's think about the potential diagnosis for this case. You can input the appropriate clinical terminology based on these findings, symptoms. You can use the PubMed or Google Scholar or UpToDate. So I can wait any responses using the Q&A or chat box. If you can use the chat box, that's okay. Or if you can use a Q&A box, that's okay. Anyone? So maybe resident physician participating in this webinar. So you are welcome to input your correct differential diagnosis. You can input findings, and you can look at the results of the clinical decision support system. Okay. Is there anyone who volunteered to show your differential diagnosis list based on your results from CDSS? So I can give you hints. Use the term appropriate clinical terminology. So I used actually for this case, using the terminology is edema and hypertrichosis and polyneuropathy. So please use the term appropriate clinical terminology. Edema, hypertrichosis, and polyneuropathy. Remember, the numbness with stocking time distribution suggests polyneuropathy. Okay, maybe there are people who actually got the lists. So let me proceed. Oh, there is a response from Jahir CJD. Oh, there is a correct answer. Congratulations. Anonymous response says Poemus syndrome, a rare paraneoplastic disorder caused by plasma cell dysplasia. Polyneuropathy, organomegaly, endocrinopathy, monoclonal plasma cell disorder, skin change, including hyperpigmentation and hair growth. Congratulations. So diagnosis is actually the patient had Poemus syndrome, which is also called as Kuro-Fukase syndrome. Fukase is the name of the Japanese doctor. So relatively rare disease, but in Japan, we see this these kind of patients sometimes. So thank you very much for participating in this case conference. Thank you very much.
Right. Thank you very much, Dr. Yasu, and also thank you to our attendees who participated in the case conference. Right. Congratulations to the one who got it correct. And now we will move on to our fourth and last speaker for this webinar. I'm pleased to introduce Dr. Jennifer Benjamin, Regional Customer Success Specialist for South Asia, Wolters Kluwer. Dr. Jennifer, please.
Thank you. Thank you for joining us today, actually, and giving us your time. So my name is Dr. Jennifer, and I'm the Regional Customer Success Specialist for South Asia. And today, for the last topic, we wanted to bring everything together to the point of clinical decision support system. So let's begin by reviewing some of the challenges the clinicians are facing today and why a clinical decision support is becoming a critical consideration. I'm also going to provide an explanation of clinical decision support system, the benefits, and how you can evaluate the impact of using a CDS solution. I'm also going to share some details about Wolters Kluwer's solution, clinical decision support solution called UpToDate. Dr. Yasuharu had also mentioned the same, and let's get started. So right now in front of you in this slide, you will be noticing the numbers of, I think the alarming numbers, what we may already be aware. So down below, you can see by 2030, there is already a prediction of 10 million doctor shortages. And the other on the right is more of US numbers, which is still, I think, even though it is the most developed country or the leader in the world, they are also facing the same shortage, which all of us are facing. So irrespective of your GDP or your economic wealth, irrespective of it, health structure is still crumbling, and when it comes to shortage and burnout. Now, we had our other panelists talking about their respective countries. I'm based out of India. So to give you a little bit of perspective, of course, WHO has given us that the ideal or the expected, doctor-patient ratio is 1:1,000. But in India, we recently had an announcement by the health ministry telling us that we have attained 1:836. Of course, if you look at it if you look at the numbers a little bit more deeper, this is after the inclusion of almost 500,000, more than 500,000 traditional medicine practitioners as well. So what it means is your Ayurvedic doctors, your homeopathy and other traditional medicine practices we follow in India, added to the more than 1 million doctors who are practicing allopathic medicine in India. Now, if you take this ratio in rural areas, of course, it's going to be even significantly worse. And there is a significant shortage of doctors now in India when it comes to community health centers. So it has jumped from a 45% in 2005 to an 80% in 2022. Now, how do you address these concerns? Now, it has become it is a requisite that you have to do a comprehensive approach. And our doctors, panelists previously have relatively done the same. So this is obviously, it includes improving your infrastructure. You have to standardize the care practices. You have to enhance the training programs and ensure a regulatory compliance. Now, how did US, of course, tackle, the growing gap? So their nurse practitioners and physicians assistant, they are now trying to fill the gap, but of course not able to do so effectively. And another great example, what we had live unfolding in front of us last year, or even so now, is the doctor strike in Korea. This was, of course, triggered by the healthcare reform plan, where they had proposed expanding the medical school admission quota in February 2024, a massive walkout by the clinicians. Almost 35% of the hospital's doctors had vanished overnight. And all we were left with, or all Korea was left with, was the remaining doctors, nurses trying to fill the gap, trying to hold the fort, essentially, and burning out in the process. So what other contributors are also, what are the contributors to the shortage? So you have your brain drain. So essentially, I think Dr. Eddie had also mentioned this, where many qualified doctors are now migrating to the other countries for better career prospects and higher salaries, and leading to a loss of talent. So now that is one place where we can tackle, where we have an infrastructure in place where it is attractive enough for them to come back to their own countries. Then we have your urban-rural imbalance. So a significant number of doctors are now preferring to work in urban areas. And of course, it is due to better infrastructure, the higher salaries, more opportunities for a career. Now, what happens? Of course, it leaves the rural areas with a severe shortage of medical professionals. And now in terms of education and training, of course, the limited medical seats when it comes to the growing population. So the population is continuing to grow. And of course, in case of India, we have become one of the most populous country in the world. And the rate at which we grew was exponential. And of course, the medical seats continue to be stagnant until the last few years. And the infrastructure, of course, continue to be inadequate, especially in case of rural healthcare facilities and the high population growth again. So of course, what happened, the demanding nature of the medical profession And when it is coupled with the inadequate support and the long working hours, it essentially led to a burnout and dissatisfaction among the doctors. So what you see in the slide now is essentially a 66% globally. The doctors and nurses are facing burnout, and 31% are essentially telling us that they are looking to leave their clinical role in the next 2 to 3 years. And the volume of decisions which a clinician has to make every day and the push to become efficient, it has made it sure that what you have always done before is not enough. Medical errors and care variability now are leading to poorer patient outcomes and lower job satisfaction. All these are weighing on and it is further, of course, impacting our patients. Now, while we talked about the immediate shortage and burnout, what else is, of course, adding to it? It is the sheer volume of medical information, and it is growing at an unprecedented rate. So if you want to add numbers into it, every year, at least 1.8 million to 2.6 million studies are being published. Articles and journals, they are being published every year. And nobody has time to go through this to ensure they are up to date and they are able to provide the best efficient care for their patients. And these latest evidence-based information, they may not be readily available to every clinician. And it is, of course, adding to the significant challenge to healthcare professionals. And in many regions, of course, there could be either absent or contradictory evidence complicating the decision-making process further. Now, resource constraints, I think this was also something we touched upon, and it was touched upon by the previous speakers. It is, again, further limiting the access to healthcare resources and reliable information. And when you have lack of access to the technology, so for example, at least in the world at a given point of time, 2.7 billion people are considered offline. And this makes it difficult for them to access the immediate up-to-date information. And it is, of course, taking away a large segment of the population. Many countries are also now lacking the ability to make this medical education training available immediately. And it is not only impacting bringing the new clinicians into practice, it is also affecting the ability of the current practitioners to stay current. Now, what happens, of course, because there are real consequences to getting it wrong, the layers of decision making now, everything is now impacting the patients. So if you look at the slides right now, so you can see how it is, of course, impacting the patients and how it is costing our healthcare system. WHO finds worldwide there is at least 1 in 300 chance of injury occurring in or during a treatment of a patient, and 10% of being harmed while in the hospital. Surgical procedures, if you take that into consideration, 7 million patients are affected with disabling complications, and 1 million die. The New England Journal of Medicine found that not even half of the patients are receiving the recommended treatments. And when you think about the cost, 42 billion US dollars are wasted when it comes to medication errors. And 15% of health spent is wasted, again, dealing with the adverse events, trying to compensate for all the complications. Ultimately, of course, all these effects are creating a storm leading to poor patient outcomes. So this is where globally hospitals are now tackling challenges through a technology stack, specifically a clinical decision support technology known as CDS. CDS is helping a healthcare professional make evidence-based diagnosis, treatment decisions while they are along their patient journey. Now, if you want to look at the numbers or the impact of a CDS solution, especially in case of UpToDate, now, a recent study shows that at least a clinician, during a clinical day, they have 15 to 20 clinical questions while they're treating their patients, right? Out of which 60% are going unanswered, which is a huge amount of uncertainty, which is driving your patient's care. And now, when they have a CDS solution at their disposal, they're able to answer those questions, and at least 5 to 8 decisions are changed. Now, when they have access to this information, at least 1/3 of the treatment decisions are improved. The rest are validated, right? And it's pretty reassuring when it comes to both clinicians as well as the administrators, and frankly, patients, because there are also embedded patient education tools, which is now going to help you as a clinician make a shared decision making with your patient and improve health literacy along the way. If you want to put numbers to Asia Pacific region, in 2024 alone, UpToDate was accessed 49 million times for topic searches and finding answers, and out of which 81% of physicians in our region have acknowledged that UpToDate has become their point of care resource. And they are also agreed, 97% agreed that UpToDate improves the quality of care provided to the patients. And 96% agreed that UpToDate is saving time for them. Now, this is again the independent studies which UpToDate, different institutions, different hospitals, everybody has conducted on. And see here, significantly fewer tests are being ordered, especially after implementing UpToDate, because better decisions are being made here. Fewer diagnostics are now being made to getting it right the first time around, and especially it helps with the hospital budgets as well. In fact, there is typically a return of investment within the first year of using UpToDate, which essentially means UpToDate is paying for itself. So what do we have? What do we have in space, or what is our future in case of UpToDate and a clinical decision support? Wolters Kluwer has always been recognized as a leader in its space, and we have been always at the forefront of innovation. There are many directions actually where our tools are being used at this point, and it is always to improve clinical efficiency and the patient outcomes. And some of them you can obviously see on this slide. Whereas what else is actually taking place right now, we are also able to revolutionize patient and chronic disease management in some key areas of medicine to improve clinical efficiency. Now, we have also found users in other domains, which is preventive patient care and value-based healthcare. What means we are to improve the quality, safety, and efficiency of healthcare and to reduce cost. So this is where I also want to mention the buzzword, of course, which is